This is part 4 of hematologic and neoplastic disorders. So we're now looking at actual cancers. So we'll look at cancers of the blood, brain, and then some other ones. So first we've got leukemia, and this is really, this is our most common childhood cancer, but this is a cancer of the bone marrow and then the lymphatic system. We used to just talk about ALL or AML as the two types, and of those two, ALL has better survival rates, but they're starting to get much more specific and complex in the classifying. So you may see other, not just ALL and AML for leukemias. Kids who have Down syndrome are 20 times more likely to get ALL than other kids. So what's the pathophysiology of leukemia? Well, it's unrestricted proliferation of immature white blood cells. So there's no actual tumor, but it's kind of, it's still a cancer like other cancers that have a solid tumor. We see the liver and the spleen become affected, but really where the problem is occurring is in the bone marrow, where we have just these cancer cells in the bone marrow making all these immature white cells. And so because of that, they use up all of the metabolic elements. Everything that the bone marrow needs to produce cells is getting used up to make these immature white cells, but the immature white cells don't work. So because of that, we get this depressed bone marrow function. They're not making red cells, so they're going to have anemia. They're not making white cells, so they've got neutropenia and risk for infection. And then they're not making platelets, so they're at risk for bleeding. The spleen, the liver, the lymph glands all can be infiltrated by these crazy abnormal white cells that are just so many of them, so you can get enlargement and fibrosis of those organs. This often infiltrates the central nervous system, so we're going to do lumbar punctures to see if we've got those cancer cells in the central nervous system. And the way we diagnose this is with a bone marrow or a bone marrow aspiration, which is exactly what it sounds like. We actually a physician punctures into through the bone, the marrow, or through the bone into the marrow, and draws some out and then looks at what's in there. Is there normal marrow or is there not? Then we're going to treat this with chemotherapy, and really our goal is to kill off the bone marrow because it's not acting right, and then usually we'll let it come back, and we're hoping that we kill off all the abnormal marrow and the normal marrow comes back. But you can imagine in the meantime, when you don't have functioning bone marrow, we've got to give you all the blood products that your bone marrow is not making. So with leukemia, prepare the child and family for procedures. Many things we do are painful. We're trying to prevent complications and infection control, right? We kill off their immune system. Even a minor illness can be life-threatening to them. Lymphomas. These are a neoplastic disorder that originates in the lymph system. And then it can metastasize to non-lymph nodes. So we have Hodgkin's and non-Hodgkin's. The difference is Hodgkin's is in a group of lymph nodes, and usually the main symptom is non-painful enlargement of a group of lymph nodes, and this happens kind of later teens. Non-Hodgkin's lymphoma happens a little younger. This is not limited to a little group of lymph nodes. It's much more pervasive. But both of them have very good survival rates. So non-Hodgkin's disease, as we said, originates in the lymph system, can often metastasize to spleen, liver, bone marrow, lungs, or other places with that asymptomatic enlarged lymph nodes, most common cervical, subclavicular, and often also cough, abdominal pain, and anorexia. You have lymph nodes everywhere, but here's kind of a picture showing some of the bigger groups of lymph nodes that are commonly a part of Hodgkin's lymphoma. So this is often treated with radiation to irradiate the nodes, and chemotherapy can be used together or alone. Really good prognosis, but we do want to prepare people for painful procedures and then help them with the side effects. Radiation is just as miserable as chemotherapy. Non-Hodgkin's, this is about 60% of pediatric lymphomas are non-Hodgkin's. It's not limited to a group of nodes, so it's much more diffuse, undifferentiated or poorly differentiated. The dissemination occurs early, often and rapidly, often in the mediastinal area or the meninges. So diagnosis is similar, but staging is different. We're still going to use radiation and chemotherapy, and even in very advanced disseminated disease, this has really good survival rates. Neuroblastoma, this is the most common malignant extracranial solid tumor of childhood. So it's outside the brain, but it is on the nerves, right? It's neuroblastoma. So most of these are on the adrenal gland or retroperitoneal, but can also be head, neck, chest, pelvis, but not in the brain. The problem with this is it metastasizes early. So metastases usually occur before the diagnosis is made. So with a neuroblastoma, we're going to try and find the primary site and all the metastatic sites. The signs and symptoms are going to depend on where it is and how big those tumors are. Radiologic studies and bone marrow will help us find them and determine what to do. We also want to look at the kidneys with intravenous pyelogram. Clinical staging is used to develop the treatment plan, but they're going to have surgery to take out the tumors. Also, let some biopsy the tumor that way. They're going to have radiation. They're going to have chemo. We may have to resort to bone marrow transplant and try saving stem cells, some stem cell rescue. With a neuroblastoma, the prognosis is not good. Generally, the younger the diagnosis is made, the better the prognosis, because it means it hasn't metastasized quite as much. But overall, this is not a good cancer. Osteosarcoma, this one occurs in the bones and most often in the long bones, the legs or the humerus, and this most often happens in teens. So we are going to do surgery to get that affected portion of the bone out. They used to just amputate, and they're now really trying to do limb salvage, where they take out the tumor and that affected bone, but then put in something, a prosthetic bone, a metal rod, something. And then with this cancer, we do chemotherapy. So here's some pictures of the osteosarcoma on a bone, right? You can see this is a femur here, and down here here's down at the distal end of the femur, because here's your tibia and fibula. So rhabdomyosarcoma, this is skeletal muscle tumor. It can be anywhere. It's usually the head and neck. Surgery to take it out, right? Tumor, and then chemotherapy. Survival is about 60% as long as it hasn't metastasized. 80% if it's diagnosed early, but late diagnosis, or if it comes back, the prognosis is poor. A Wilms tumor. This is a tumor that's encapsulated, and it is on the kidney. It arises from the kidney. So this is painless, but they'll have a mass on one side of the abdomen. This is usually kids who are quite small, like, maybe at the 18-month visit, the doctor will notice this non-symmetrical abdomen. So treatment is surgery to take it out, and then chemotherapy, possibly radiation. Survival rates are very good as long as the tumor stays encapsulated. So the most important thing we can do is not break that capsule that's around the tumor, which means do not palpate the abdomen until they've done surgery and taken it out. And when they take it out, they take the kidney out with it. So that's how they stage it. And as long as it's encapsulated, outcomes are good. Retinoblastoma. This is a tumor of the retina of the eye. It usually happens on one side, usually non-hereditary, but there are some exceptions to that. What you're going to see is this white glow, or they'll call it a cat's eye reflex. So during an ophthalmic evaluation is how they'll find and diagnose it. Doesn't usually metastasize. And they often can save the eye. They'll do radiation to destroy the tumor and destroy the blood supply to the tumor, and hopefully be able to save the majority of the retina of that eye. And here's what you see. You can see they've really dilated those pupils, but you're seeing the tumor instead of the retina back there.